Right. Good evening, everyone. Sorry for making this a bit later. I had some other obligations during the day, but thank you very much for joining at this time. So today I'm going to be talking about chronic pancreatitis. Let's just make this full. Okay, why are we not changing? Okay, so as always, the Our meetings are hosted by the Gastro Foundation, but it's together with the association with the Project of ECHO, which comes from the University of New Mexico. So yeah, let's get on with the presentation. So I'm gonna have to do this on the screen by the looks of it. Okay. Right, so what I'm gonna talk about just very briefly is the first two, because this really should be background knowledge for you. But there is a new Tiger O edition that came out, so just briefly going to go over that, and then very superficially talk about an approach to chronic pancreatitis. And then the bulk of what I'm going to go through today is on pancreatic cancer and chronic pancreatitis, dealing with pain and some new pain perspectives. And then something that I think is often lacking is sorry, this is going to be a bit painful if I have to keep doing this all the time. Is diabetes mellitus specific to pancreatic diseases? The way I've structured this is I don't really want to make this into a lecture, so I've chosen articles and publications for each of these topics. I don't have fixed slides as such. You are more than welcome to actually unmute yourself. Then you can introduce yourself, because I won't be able to see who you are, and just ask you a question, because hopefully this will be a little bit interactive, and we go from there. So good. And what I'll also do is at the end of this presentation, all the publications that I talk about during my presentation, I will email them to Karen, and then she can forward them to you. So all of the publications and all the studies that we're going to go through, I will forward you the publications. So you'll probably get them tomorrow or the day after. So if we look at Tiger O, and if we remember what Tiger O stands for, it's around the etiology. So toxins, idiopathic, genetic, autoimmune, recurrent, and obstructive. The first version of this came out really around about 2000. So this has been updated, and in the update, what's nice about it, it's got a short list and then quite a longer list. And I found the short list is quite useful when one talks about the etiology of chronic pancreatitis. So just like we always have, so the Tiger O hasn't actually changed, but quite a bit of the content of it has. So if we look at under toxic metabolic, what's a bit different is that they've actually defined the amount of alcohol intake, but where they're also more defined is under hypercalcemia and hypertriglyceridemia, that they're actually giving you specific numbers. And I think at a subspecialist level, this kind of information is actually quite important that you realize it. Idiopathic is now they're formally included. I wonder how I can get rid of this toolbar. Can I get rid of the toolbar? No, I can't. Okay, that's a pity. Let's just go back.
I don't see a toolbar from my side.
Yeah, but I'm looking for this. You are screen sharing and stop share to move out of the screen. How do I do that?
Oh, no, that has to stay there.
That's like right in the middle of my writing. Anyway, so be it.
I don't see it on my screen, so I'm hoping everyone else will see what I'm seeing.
Oh, okay, I didn't know that. Okay, because for me, it's quite irritating. Okay, anyway, continuing, thank you. So under idiopathic, they've defined early and late, and that being under the age of 35 and over 35. And they've expanded quite a bit under the genetic causes. So even though I've just given you the tables, if you go into the paragraphs and read around them, especially around the PRES1 and the cystic fibrosis genes. Again, that's information that you need to know about, and it's not going to be in the scope of my presentation today. And then under autoimmune, they've obviously divided it into type 1 and type 2, which is also new for the Tiger O. And then under these two haven't really changed much at all. With recurrent acute, they've just given a few more causes of recurrent acute pancreatitis, and then the obstructive hasn't changed at all. But what's also different is that this is what I've given now as is what's called a short form. And then if there are any etiologies that are actually positive or present in a short form, the instruction is then to go into the longer form where you get a lot more detail around it. And the whole idea of knowing about the Tiger O is that, especially with counseling patients who've got risk factors, be it autoimmune pancreatitis, etc., if you do the long form, it's a fill-in form, you're actually able to calculate the risk for developing chronic pancreatitis. So it is actually quite a nice updated version and something that you really must know about. The other side that I'm not going to talk much about, and it's quite an old publication, 2010, but it's still very useful, and I think should be the basis of how you approach any new patient with chronic pancreatitis in your practice. What is nice, it is a South African guideline, and even though it is a bit dated, it is still very relevant. And what it really brings home to you, and interestingly enough, for the students today in the FCA, or the registrars in the FCS exam, the one clinical case was on chronic pancreatitis. And it's a bit disappointing in the way that a lot of the registrars were not actually able to identify the multidisciplinary approach to initially the investigation and then also the management of chronic pancreatitis. And I think really at a subspecialist level, you must be really very well versed with chronic pancreatitis at a multidisciplinary level and the roles of the various disciplines. So the role of the endocrinologist, the role of the dietitian, the role of the psychologist, etc. And this guideline really brings that home to you, although it is quite superficial, but it gives you the background to the management and approach to these patients. And then I would recommend that you start reading around each of those issues. And that's what we're going to start going into more in this presentation. Is there a comment for me in the chat room? Oh, okay, never mind, sorry. Right, let's carry on. Okay, so I think what's becoming quite topical is pancreatic cancer in patients who have chronic pancreatitis. And we are seeing quite a few publications now coming out with this. So this is the first area that I do want to focus on. So the first one is obviously around how common is pancreatic cancer in patients with chronic pancreatitis. And this is a very nice meta-analysis that was published in 2017. And what they did is they included 13 observational studies. And what is nice about this study, which is different from previous studies, is that they looked at different lag periods. And what the lag period means is from the time of diagnosis, so when the patient is conclusively diagnosed with chronic pancreatitis, and then you follow them up over 1 year, 2 years, 5 years, and then they ended up going up to 9 years. And so they published these forest plots, and just to summarize them for you. So one of the findings of this meta-analysis was that 5% of pancreatic cancer patients were actually misdiagnosed at the time of diagnosis of chronic pancreatitis. And so this really raises the question that even though you may have a stock standard barn door type chronic pancreatitis maybe with your imaging, you must always just keep in mind that that patient has come to you. And I mean, one of the things that we say where you become suspicious of a cancer developing in a patient with chronic pancreatitis is that their stable symptomology has just changed. In a way, a patient who presents to you for the first time most likely came to you because they also had a change in symptoms, and you need to keep that in mind. So it may be a red flag that those patients have pancreatic cancer. And so in the old days, before EUS was readily available, we always used to say that we would start with a pancreatic protocol CT scan and have a look at that. And that would be your baseline CT scan. I think what's changing, especially with this statistic of 5% of pancreatic cancers being missed, is that most of these patients are actually good candidates for an endoscopic ultrasound. And especially if there's a mass in the head of the pancreas, or they have disease that is isolated to the head of the pancreas, we should have a very low threshold in that very early stage to do an endoscopic ultrasound. And then and if there are suspicious areas and there are masses, etc., to be very quite liberal with the use of endoscopic ultrasound and biopsy. And then if we get into, so if we have a look at the 1-year lag period, so their risk for developing pancreatic cancer is 6 times that of the general population. So a population who does not have chronic pancreatitis, which is roughly the number that we think, that we usually quote, because we often think around about 8. What is eye-opening, though, is that after 2 years, the risk is 16 times that of the general population. So that's phenomenally high. So the risk for pancreatic cancer in the first 2 years, especially, is significant. And then what's very interesting, and this is probably one of the first meta-analyses that's shown this, is that from there on, the risk actually starts to drop off. And that by 5 years, the risk is actually lower than what it was at 1 year. It's less than 5 times. And if you look at, they didn't give us 9, sorry. And at 9 years, it is round about 3 times. So what this study has shown us is that we should probably be far more vigilant with our patients in the first 2 years after the diagnosis of their chronic pancreatitis. And that maybe we should be a lot more aggressive in our management and follow-up of them in that time period. And once we get them through those first 2 years of follow-up, then we can maybe start looking at extending the follow-up and not being as aggressive with those patients. But what this study really nicely shows for me is 2 things. The one is there is a significant proportion of patients who have a pancreatic cancer at presentation, and that we should probably be more aggressive with our initial investigations, because EUS never used to be part of our initial investigations in the chronic pancreatitis, and it probably should be. And that our follow-up for the first 2 years after diagnosis needs to be a lot closer than what we think is the case. So what do we do for these patients that have a mass in the head of the pancreas? How do we go about determining whether or not it's chronic pancreatitis or it's a pancreatic cancer? And again, this is a very nice study. It's not the highest level publication that you'll ever find, but I must say it's written very well. It's very easy to read, and I would actually recommend that one uses it. And it really gives you a problem-solving approach to determining whether or not your patient has got a pancreatic cancer. I'm not going to go through this in too much detail. What this article has a lot of are teaching points in these kind of squares, which are really nice to read around. I'm not going to read you what's on the screen, but it really goes more around about the anatomy of the strictures, the anatomy of the head of the pancreas, vascular involvement, etc. And I think they have a really nice summary table. And the rest of the paper really describes the various components of what's in this table in a lot more detail. And the study actually just has quite a few images that go with it. So this is actually, even though it's, if you look at it first up, you wouldn't really think it's a subspecialist level kind of publication. But for me, it was actually quite nice to read and very reliable. And it gives you information really, which I wasn't really aware of, and I didn't look at much, is specifically is the duct to parenchyma ratio. So in other words, the greater the duct dilatation, the greater the likelihood that the mass in the head of the pancreas is malignant, which is something that I never really looked at. For me, it was always an atrophic pancreas, and one attributed the pancreatic atrophy more to the chronic pancreatitis. But there is actually significant data around the fact that the greater the dilatation of the main pancreatic duct and the less parenchyma present, the higher the likelihood of there being a pancreatic cancer. The other sign that I must say I also wasn't very much aware of is what they called displaced calcifications. So normally you would have calcifications fairly well spread out through the head and body of the pancreas. And especially if you've got a baseline CT scan and then you follow the patient up and get another CT scan, if you compare the pattern of calcification, what they mean by displaced is that the pancreatic cancer very rarely actually calcifies. And so what it will do is, as it develops, it starts pushing the calcifications away. So all of a sudden you might have an area in the head of the pancreas that is not necessarily hypoechoic, it's often isodense which is not unusual for a pancreatic cancer. But the calcifications have been pushed away from that area. They've been pushed away towards the periphery. And that is an area that you really need to be suspicious of and really warrants an endoscopic ultrasound and biopsy of that area that has got actually a paucity of calcifications. And then the rest are fairly well described. But this is definitely a worthwhile read to get a good approach to differentiating an inflammatory or pseudo-inflammatory head of pancreas mass with the head of pancreas cancer. So then the next question obviously is, how do we prevent pancreatic cancer developing in patients with chronic pancreatitis? And there's quite a few publications that have come out around about surgery, when to do it, and what surgical procedures to do. So this is probably the study that has changed my practice and my view of when to operate in a patient with chronic pancreatitis. And apart from all of the other perceived benefits of pain relief, of halting the progression of the exocrine and endocrine dysfunction, it's really this study, this Japanese, it's a multi-center, unfortunately it's retrospective, but I think one can still take the data on value. But this is a Japanese study, and it was one of the first studies that actually came out with a significant number of patients where they actually showed this. So they were able to include 506 patients diagnosed with chronic pancreatitis, and they followed these patients up for 2 years from the time of their diagnosis, and 10 of these patients developed pancreatic cancer. So they compared patients out of these 506, 147 of their patients actually underwent surgical procedures. The vast majority of the surgical procedures that they underwent were drainage procedures or resectional procedures. So the most common procedure that they did was a fray. And then with resection, quite a number of patients had a Whipple's procedure. And so I'm going to show you two graphs from that, from the study. So the first graph is really those patients who did not have surgery, and that is the dotted line that you see in this graph. And those that underwent surgery is a solid line. So it's 352 versus 147. And it's a cumulative incidence of pancreatic cancer. And you can really see there's quite a significant difference between those patients who underwent surgery and then was followed up, and they actually followed them up for a lot longer. So what than 2 years. The reason why they chose 2 years is that was a group of patients that underwent surgery within 2 years of diagnosis. So early surgery effectively, and then they followed them up for as long as they could, etc. And so those patients who never underwent surgery obviously had the same follow-up period. And what you can see, there's quite a divergence between the two groups. And this is probably the first study that showed that. And in a very interesting sub-analysis in this same population is patients who actually stopped their risk factors. So the primary risk factor in Japan that they realized is actually alcohol abuse. And so they did a sub-analysis of patients that continued to use alcohol. And that's in this graph is patients who've got a solid line. And then for patients that stopped drinking, it's the dashed line. And then the dotted line is for patients where they don't actually know whether or not they truly stopped or did not stop. So and unfortunately, it's a fairly significant number, but I think 192 versus 183 is also interesting. And again, you can see there's a distinct relationship between patients who continue to abuse alcohol, despite whatever treatment they have, that their risk of getting a malignancy is far higher than those patients who stop using alcohol. So I think this study quite clearly shows that a large component of our treatment or management of patients with chronic pancreatitis must be to get them to stop drinking alcohol. And going back to that SAMJ paper that I'd cited a few slides ago, part of the management there for substance abuse, and the substance abuse these patients typically have is alcohol, smoking, and opiate abuse. Part of that management has to be that they join psychology groups, etc. They're not going to stop their abuse on their own without added interventions, and they do need a lot of ancillary interventions. So it really is a multidisciplinary approach to managing that. If we look at pain, and now I can't read that, sorry. Oh yeah, okay. So this is actually quite an old study, and hopefully you guys are aware of it, but if you're not, we're going to discuss it briefly. So it's the endoscopic versus surgical management primarily aimed in pain, where the pain is attributed primarily due to a dilated main pancreatic duct in patients who are known to have chronic pancreatitis. So Guma here, and this is a Dutch group, and Guma was actually one of the main protagonists of this. He was very well known for endoscopic management of chronic pancreatitis. And so they came up with a randomized controlled trial that they got published in the New England Journal of Medicine. So it is a decent study, even though it's relatively small numbers. So they randomized only 39 patients, and of those 39, 19 were randomized to endoscopy. That endoscopy included obviously ERCP, and then they put in a pancreatic duct stent. And in 10 of those patients, they also did lithotripsy of stones that were in the main pancreatic duct and then cleared out the duct. So it's quite a interventional endoscopy. And then 20 patients were randomized and did not have any endoscopic procedures. They just went straight away for a pancreaticojejunostomy. They followed these patients up for 24 months. And what they found was there was a significant difference in pain scores, whichever one that one uses, but the primary one in the study was the Tsubiki pain score. And as you can see, for those who had endoscopy, their average pain score was 51, which is quite high, considering that the pain score before they had the endoscopy was about 68. So it's not a really big jump. And for those who had pancreaticojejunostomy, their pain score dropped right down to 25. Both sets of patients had very similar quality of life scores, and pain relief or complete pain relief was almost 3/4 of patients in the surgical group versus only 1/3 of patients in an endoscopically treated group. And I think this study quite nicely showed that these patients, especially for pain management, do much better with a surgical intervention than they do with endoscopy. And the other problem with endoscopy is that they require multiple re-interventions. And actually what happened at the end of the study is those 19 patients, actually most of those underwent surgical intervention, and those that underwent surgical intervention from that endoscopy group had very similar results. And this was actually published in a separate paper. There's a really nice guideline published in 2017, so it's the most recent guideline that I could find about understanding the management of pain and chronic pancreatitis. It is a consensus guideline, and what that means is it's done according to a Delphi process. What a Delphi process means is that you have a panel of experts, which are those that you can see in the citation there. They come up with a group of questions that they feel are relevant to the management of pain in chronic pancreatitis, and then they email that group of those questions out to all and sundry HPV people, and they try and get as many of those people to give an input and their opinions of it. And then this panel then sits down and then they go through all the responses to each question, and then they weight the responses, and then they draft a document such as this. It's quite a laborious way of doing it, but it is actually, in my mind, it's probably a very good way of doing this, because you actually do get a lot of different opinions and weighting of opinions. So it is quite an effective way of studying. So I'm just going to choose a few of these questions that they had. So one of the questions was, do enzymes and antioxidants influence the management of pain and chronic pancreatitis? The reason why I chose this is that there always used to be a lot of debate about whether or not Creon was actually used for pain management, and we could use it. And I think in our environment, or in the circles where I qualified, we often didn't believe that at all, and that Creon was purely there for exocrine dysfunction and had very little input or impact on the management of pain and chronic pancreatitis. And so they came out with this recommendation, where pancreatic enzyme therapy with a high protease contents could actually be used in the initial management of pain management for these patients. And if you consider that we use the World Health Organization ladder, that we actually enter Creon into that ladder, which typically it isn't a component of that. Antioxidants also is something that we don't commonly use. However, in the publication, and what you'll see is when you get the publication and you start reading it, they have these questions and then they have the justification with the citations thereafter to justify their statement. So you obviously haven't put that material here. But they've also, what's different found is that antioxidants, especially in very high dose antioxidants, and the antioxidants that they talk of primarily is vitamin C, vitamin E, and selenium. And I think vitamin C is something that's quite readily available, vitamin E as well. So is actually selenium. And if one uses those together with your enzyme replacement therapy, are actually quite effective in the early management of pain. It isn't as effective in severe pain, but in patients with an initial management, it's definitely worthwhile trying. So for me, that was actually quite new. Just because we've just gone through endoscopic management from that Dutch study, one of their questions was also, is endoscopic therapy effective? And so here they're talking primarily of pancreatic duct pathology. And so I think this is probably correct, that there are very few indications for first-line endoscopic therapy. And really the main one is that you've got a distal obstruction. So it needs to be an obstruction that is easily reachable via ERCP. So it needs to be quite distal in the main pancreatic duct. And it can only really be a single stone or a single stricture. So it's a very rare condition to have, or situation to have, especially if you look at our chronic pancreatitis in our country. They tend to really have a typical chain of lakes appearance in their main pancreatic duct. And so those patients are definitely not really good candidates at all for endoscopic treatment. They also talk about combining extracorporeal shockwave lithotripsy, but again, this is really only if you have a single large stone, and the large stone that they've defined as is 4 millimeters causing the problem. Again, the stone needs to be located in the head of the pancreas. So again, the reason for that is that you're able to stent past it with ERCP. So again, endoscopic therapy is for a very small proportion of patients, and probably for the patients that we typically see in our country is not really of use. What is also nice in this guideline is they talk about the optimal timing of surgery, and there's a lot of debate in the literature, and I think the debate is pretty much settling, is that early surgery in these patients is becoming more and more indicated, especially for the management of their pain. And I remember when I was training, there was a statement that always used to be said that a chronic pancreatitis patient must earn their Frey procedure. And how did a patient earn their procedure? It was that they were on the opiates, and that the opiates weren't actually controlling their pain. And I think we've come a very long way from those days, in the sense that we are looking at actually preempting opiate dependence. And we actually want to try getting patients that we see are progressing with pain, their symptoms are progressing. We haven't necessarily started them on opiates yet. That's really a good group of patients to consider doing your drainage and resectional procedures. So they give 3 categories of patients in this guideline. So the one is, and it's very liberal, is within the first 2 or 3 years of diagnosis or symptom onset. So that's a very broad criteria for patients. So it's pretty much all patients with chronic pancreatitis effectively. They also then have a category where patients have had equal to or fewer than 5 endoscopic procedures, and they have patients who have not yet required opiates. So if you look at that guideline, and as I say, in the actual manuscript, they do back up their statements with literature, we really should be changing the way we look at chronic pancreatitis in South Africa, and that we really should now be looking at patients when they come and see us for the first time. We should already have in the back of our mind, when are we going to be operating on this patient? When are we going to offer them a Frey? I think it becomes a bit of a no-brainer once they've got obstructive jaundice, because the studies have shown that obviously with patients with chronic pancreatitis and obstructive jaundice, endoscopy really doesn't work in these patients. They all require re-intervention after re-intervention, repeat stenting and repeat stenting. So I think obstructive jaundice is a no-brainer. But where we need to really start contemplating is the patients who don't have obstructive jaundice but do have pain. Should we not be operating on them a lot sooner than what we currently are doing? And then how do we manage relapse? Okay, so the patients will relapse after surgery. And I must say, observational studies from my experience with Frey procedures, I think a Frey procedure tends to buy a patient about 3 or 4 years of significant pain relief, if not complete pain relief. But then the majority of patients tend to start relapsing with their pain. And typically those are the patients who've continued to smoke and continue to use alcohol, which fits in again with that Japanese study that their symptoms don't necessarily resolve and that they're also at higher risk of developing pancreatic cancer. But when a patient relapses after the surgery, the first step must be to look and see that there isn't a complication of the surgery, that none of your anastomoses have strictured down, for example, depending on what kind of procedure that you've done. And then obviously we have to fall back onto endoscopic procedures. And here, probably the endoscopic interventions that we need to look at are really endoscopic ultrasound with celiac axis blocks, etc. In this paper, they also go on to talk about splanchnic splanchnictomies, splanchnic nerve splanchnictomies, etc. And there's limited evidence around it. However, it is an option for it. I think what one does need to realize, though, is that these patients do tend to relapse. I must say, in my experience, though, when they do relapse, the pain is usually not as severe as what it was before. And one tends to usually be able to manage them with oral medications, not necessarily opiates. The ones that are in severe pain tend to have a complication that can be managed. So this is a very nice flow diagram at the end of this publication, which summarizes their approach to how they deal with pain. And what you can see is that surgery is really quite early up in this flow diagram. So obviously the first step has to be that you have to make the correct diagnosis. And we do that, as we said, with imaging. And again, as I said, we have a very low threshold for endoscopic ultrasound a lot earlier, especially if there's suspicious areas. And that follows on from that radiology paper where there's suspicious features with the pushing away of the calcifications with a very wide duct, etc. We must make sure that there aren't alternative diseases, especially in patients who don't have a high burden of calcifications. Those patients, you really do need to start thinking of a differential diagnosis. Obviously, the first one has to be pancreatic cancer, but then also cystic lesions, IPMN, especially side branch IPMN, large pseudocysts in the head of the pancreas, etc. You must remember also that patients who've had acute pancreatitis, if they've had any necrosis from that acute pancreatitis, they can get dystrophic calcification in that pancreatic necrosis. And that dystrophic calcification is not a sign of chronic pancreatitis. So if you do have calcification in chronic pancreatitis, but it's very isolated, again, you need to question whether or not that is true chronic pancreatitis, or whether or not there's maybe dystrophic calcification that you've got in a patient who had some acute pancreatitis with a bit of necrosis. Okay, but as I said, this is quite a nice paper to read. They also had a lot more detailed flow diagrams. So when you get this paper, I suggest you read it in quite detail. So what is the role for endoscopic ultrasound in the management of pain? And so this is also quite an old study, but it's quite an interesting study. And I haven't seen many studies after this meta-analysis that have come out and actually with results that are much different from this meta-analysis. So this meta-analysis looked at 2 groups of patients that had severe pain. The one is a group of patients with chronic pancreatitis, and the other was patients that had pancreatic cancer and how to deal with that pain. So this is the first group, which is the patients who had chronic sorry, let me just make sure that I'm telling you the right. Yeah. So this is the first group of patients in the forest plot that had chronic pancreatitis. And what is really surprising here, I found, is that only around about 60% of patients had significant pain relief. And again, significant pain relief was defined by various scores that people used. And when we talk about an EUS block, it's a bilateral celiac block. It's not a unilateral block, so it's a properly done block. they actually excluded studies that did unilateral blocks. So only 60% of patients actually had durable induced pain relief, which is actually not as high as what we often think. What is interesting, though, is in the pancreatic cancer group, 85% of patients had relief of their pain. Okay. And I think what this really speaks to is that the mechanism of pain is different between these two groups of patients. Chronic pancreatitis patients, they will have fibrosis or chronic inflammation around those nerve plexuses. They will then have fibrosis. And I think that is far more durable, whereas the patients who have got pancreatic cancer don't necessarily have that chronic inflammation. It's a far more acute process with tumor infiltration. So it's a different mechanism that affects these celiac nerves. And that probably is the reason why the pain relief is more durable. What this study actually does say to me, though, is that we should probably have a lower threshold to offering patients with chronic pancreatic cancer, a lot lower threshold to offering them EUS-guided blocks, which is something that I must say we don't really follow in my practice, and it's something that one needs to consider about. What the study also shows is that you really do need to counsel your patients that the EUS-guided celiac axis blocks is not the panacea for their pain. The other problem that we have is there's a small subgroup of these patients who will have significant relapse of their pain as well. And that pain can be quite severe. And then to finish off with, the last component of this presentation is around diabetes mellitus and chronic pancreatitis. And the reason why I've put this in is I find when we have discussions around patients that the pancreatic or pancreatocogenic diabetes is not something that is very well understood. So I've got a very nice review article that I really do recommend you read. Yes, it is very medical, but I think as gastroenterologists, we do need to understand type 3C pancreatocogenic diabetes, and so that we can understand it, that we can manage it manage it better, because it is managed differently to the traditional type 2 and type 1 diabetes. So what is the prevalence of this disease? Well, if we look at all diabetics, it's less than 10%, and depending what one reads and what populations, it's 1 to 9%. However, if you look at chronic pancreatitis patients and you look at their diabetes, up to 80% of their diabetes is actually type 3C. And so it's a significant proportion of chronic pancreatitis that have type 3C diabetes. So the diagnostic criteria for this diabetes, it was proposed quite a while ago by these two gentlemen, and the diagnostic criteria haven't really changed. There's majors and minors. There's only 3 major criteria, and all 3 of these criteria must be present for you to be able to diagnose type 3C. So pancreatic insufficiency, so that it makes it a pancreatic, or so that there's associated exocrine insufficiency as well. So one does that, obviously, as we always do with the fecal elastase test. There have to be pancreatic abnormalities in keeping with chronic pancreatitis. Obviously, if it's clearly chronic pancreatitis on a CT scan, it's fine. However, if it's more subtle, we should be doing an endoscopic ultrasound, and we should be using criteria like the Rosemont criteria to diagnose chronic pancreatitis in these patients. And we have to prove that there is no type 1 diabetes, and there's autoimmune markers for type 1 diabetes. Once you've got all 3 of those, you then look at the minor criteria, and you only require 1 of these minor criteria. And probably the easiest one is to show that there's also impaired beta cell function. So part of it, the testing that we should do is insulin levels with C-peptides. That will confirm that there's beta cell dysfunction. Absence of insulin resistance is a little bit more difficult to prove. Impaired incretin secretion, again, is also more difficult to prove. It's really something that's come to the fore with metabolic or surgery. And then what one can show is also low concentrations of lipid-soluble vitamins. And again, this has got a lot to do with pancreatic insufficiency, but you only require one of these. So it's 3 + 1, and then you've got your type 3C diabetes. Why is it important to know about this? It's because of the management of their hyperglycemia is different to a traditional type 2 or type 1 diabetic. So as usual, we would use metformin mostly up front, but these patients are quite resistant to metformin, so most of them will end up on insulin. And this is where the challenge then starts coming in. So you can consider using metformin if the HbA1c is really not high. If you consider 7.2 and above is what we use to diagnose the condition with, there's very little room for metformin. So the vast minority, if any of your patients, will ever get on to metformin. So we have a very low threshold to start them on insulin. However, what you must remember is that chronic pancreatitis patients have enhanced peripheral insulin sensitivity. And there's various mechanisms for this, and those mechanisms are described in quite a bit of detail in this publication. But what it means is that you really must be careful of hypoglycemia. So what it means is that what one would expect in these patients that you would have to be giving them quite high doses of insulin, but it actually is not that. It is that you have to give them lower doses of insulin. You have to use short-acting insulins. The patients have to monitor their own glucose regularly through the day, and they have to be able to adjust the dose of short-acting insulin that they give themselves. These are not patients that should be given long-acting insulin. So that is the first significant difference between patients with type 1 and type 2 diabetes. And then the next difference is that you should treat their exocrine insufficiency quite aggressively. Okay, and why you need to use your exocrine insufficiency is that because if you manage the exocrine insufficiency, you increase the secretion of incretin in the duodenum and small bowel, and that improves the glycemic control indirectly, and therefore lowers your requirement for insulin. So the major differences is that you're going to use insulin a lot earlier, but you're going to use a short-acting insulin. You cannot give these patients long-acting insulin because they are going to become hypoglycemic, and they have to monitor themselves very regularly during the day. And the last component of this is that you have to treat the exocrine insufficiency very aggressively. And I think that is the end of my presentation. So I kept it nice and short and sweet. As I said, all of the publications that I've discussed in this presentation, I will forward to Karen to forward it to you. And like what I would like to do now after going through the thank yous. So we have to say again, thank you to ECHO and the ECHO India team for their support. Please fill in the feedback form. We really do like feedback, positive or negative, because it can make these things better. This session has been recorded and will be available on the Gastro Foundation website. And as always, we have to say very much thank you to the Gastro Foundation for supporting gastroenterology training and subspecialist training. Next week, the topic is oncology. I'm not sure what in oncology, and it's going to be given by an oncologist, Dr. Barbara Robertson, but I'm sure more information will follow on that. So I'm going to stop my screen share now, and I'm going to be quite keen for you to ask your questions along of what I've been discussing, and hopefully we can have some debate. So I'm going to stop the share. And I see there's a hand up. I also see there's comments. Let's see. VG, thanks for the reference. Incredibly difficult to find Cancer Island and Ocean to score at EOS. Agreed. I think there's a place for biliary stenting in chronic pancreatitis patients with jaundice. Patient poor nutritional state, gives you a few weeks to improve their biodegradable stents for the future. Definitely agreed. So I think for me, and I agree 100%, is these patients, in the majority of these patients are malnourished and are in very poor form. So just like what we would do for pancreatic cancer patients, where we also are very much, and surgeons are very much anti-biliary drainage, is nutritional rehabilitation. And so for nutritional rehabilitation, internal biliary drainage is definitely required. So I would agree with you, VG. That is, for me, that's also a definite diagnosis, reason to do it. I think the debate that we can have, though, is in these patients that are going to have nutritional rehabilitation, if they're not going, well, obviously chronic pancreatitis is not going for neoadjuvant chemotherapy, so maybe I shouldn't bring in the chronic cancer patients. But what we can maybe debate is whether or not one should just use a plastic stent versus a self-expanding covered metal stent. Because from a surgical point of view, when we do a hepatojejunostomy onto a biliary tree that's been drained, I must say, operating on a bile duct that's had a self-expanding metal stent, it can be quite unpleasant because the bile duct wall tends to be very inflamed. It tends to be very much thickened, far more than with a plastic stent. So maybe, I mean, that's what our practice is that we would put in a plastic stent for these patients that need nutritional rehabilitation. But what I do want to highlight, though, is this nutritional rehabilitation and stenting is different to those with pancreatic cancer, because the majority of those patients with pancreatic cancer are going to go for the neoadjuvant chemotherapy. And in that scenario, you've got the nutritional rehabilitation, the neoadjuvant chemotherapy. In my mind, those patients are going to be gone from your practice for at least 3 months. Usually they go for a little bit longer than that, considering the complications of chemo and the timing and all of that. So in that group of patients, I would use a covered self-expanding metal stent. Right, I think from now on, I'm going to take questions. I'm not going to look at the chat, I'm going to look at hands. Let's just draw up this. So I think the first hand that I saw was by, I'm just going to say your first name, Yelda. So you can unmute yourself and ask your question, please.
Hi, yeah, I know my second name is difficult. Thank you for the nice presentation. Dr. Martin, I have actually 2 questions. One is regarding we know that the current studies, they advocate for an early surgery rather than continuing with the EUS. But if I have a patient who's not having the criteria, perfect criteria for an EUS, dilated duct, having the pain, in these situations, would you go directly for a surgery or you're gonna attempt some EUSs? Like most of the studies shows at least an attempt of less than 5 before attempting the surgery. So I just wanted to know your intake in that.
Yeah, so my opinion is, I must say, I am an aggressive surgeon when it comes to that. So I have a very low threshold for offering surgery nowadays to patients with chronic pancreatitis. So for me, it depends on the patient. So if the patient presents to you and they already have quite severe pain and they tend to be almost using opiates, but maybe not, they're not on morphine, but maybe they're using codeine or drugs like tramadol, for me, that's already a sign that they're well on their way to opiates, to be requiring opiates. That kind of a patient, very low threshold to operate on them up front early. What I would do in that patient, if they've got no other issues, so no obstructive jaundice, etc., I tend to follow them up maybe for about 6 months. And in those 6 months, one would see them for at least twice. And what one would do is just to really get on top of their pain management to see if they really are as severe and analgesic requiring as they claimed at their first visit. And if they still are after those 6 months, very low threshold to offer them a surgical intervention, depending on what their pathology is. If a patient comes with obstructive jaundice, for me, and they have chronic pancreatitis, they've already signed the ticket, they are candidates for surgery. And as Vijay mentioned in the chat room, they need to be operable. So that's the only thing that would delay me in offering that patient surgery is whether or not they're operable. And the major reason they would not be operable is obviously with their malnutrition. So those patients, I tend to drain them, put in a plastic stent for them, try rehabilitate them, get on top of their diabetes, also get on top of their exocrine dysfunction. One has to see that they pick up weight. The albumin often lags quite significantly. But again, it's a benign condition. So unlike pancreatic cancer, So again, I draw that analogy with nutritional rehabilitation for pancreatic cancer. My end goal is slightly different for chronic pancreatitis. It's a benign disease. I would like to see that a chronic pancreatitis patient's albumin comes towards the level of 28 and above. Whereas for me, with pancreatic cancer, that's not necessarily the case, because I don't like to hang around that long with pancreatic cancer. So I'm not as strict on an albumin level in that. What I do want to see is that the patient becomes anabolic. So I do want to see that there's a positive trend in their albumin, and I want to see that they start to pick up weight. So, and I tend to operate pancreatic cancers a little bit more early than I would in that situation. So I hope I'm answering your question.
Yes, thank you. And the second one is actually regarding the celiac axis block. The studies, most of them, when they're comparing the chronic pancreatitis or the pancreatic cancer, in the cancer, they're using mainly neurolysis with 100% alcohol, while in chronic pancreatitis, because it's a benign condition, most of the studies, they don't go with alcohol, they go with the local anesthesia like bupivacaine and lidocaine. And we know that the effects of them are not going to be for a long time, it's going to be for a few months. Is that the reason why the number of the patients who are benefiting with the chronic pancreatitis with the block on the literature is low?
That's a good observation. I think, if you look at that meta-analysis, though, the follow-up period, actually, they start looking at patients from 1 month after the procedure. And even at 1 month after the procedure, the response to the blocks is significantly lower than in patients with pancreatic cancer. I hear what you're saying, and it's a good observation that in pancreatic cancer, we tend to use neurolysis. However, I think... Okay, sorry about that. I think what you're going to see, though, in pancreatic cancer is that we're going to follow the same route as chronic pancreatitis, because with our chemotherapy agents, we are seeing that our patients are surviving a lot longer. The problem with the neurolysis is that they get recurrent pain or relapse of their pain, and that pain is really quite severe. And so I think we're going to see going forward that we're going to start using more of the chronic pancreatitis type blocks with the longer acting blocks with bupivacaine and steroids, etc., that we use. But yeah, that's a good observation. But in that meta-analysis, they actually showed after 1 month, there also was a significant difference.
Okay, thank you so much.
Good. The next hand that I see up is Mohammed Saror.
Yes, Brian, thank you. Thank you for the nice illustrated presentation. My question is that for your surgical selection, procedure selection, so the literature is prescribing such kind of variable outcome in terms of these different procedures. So either the pancreaticoduodenectomy or the duodenal preserving resection of the head of the pancreas with its modifications, burgers and brain, and these things regarding the short-term control of pain and long-term control of pain and the quality of life as well, mortality, morbidity. So there is kind of quite variable degrees of outcome in this procedure. What is your approach for selecting these patients to a specific type of procedure?
Yeah, that's a good question. Thanks. So I think the one question that one has to answer first is, are you suspicious of there being a pancreatic cancer in the patient, yes or no? If you are suspicious of there being a pancreatic cancer, you need to do an oncological procedure. Typically, these patients get ahead of pancreas cancer. So if you are suspicious of that, then we'll have to get a Whipple's procedure. And then the question becomes, what are you going to do with the rest of the duct if you're concerned about that? And again, it depends on the pathology that you're seeing. So if the duct has a single stricture in that scenario, then you don't need to actually do a drainage procedure for the body and tail. You just do your normal reconstruction of whatever you do with your pancreas, pancreaticogastrostomy, pancreaticojejunostomy. if you are not concerned about whether or not there's a malignancy, I think it will also depend on the pattern of chronic pancreatitis that you see in your practice. So I think in our country, our chronic pancreatitis tends to affect, let me just let them in. Our chronic pancreatitis tends to affect the whole body, the whole organ. It's not isolated to the head of the pancreas, which it's seemingly, from the literature, seems to be more common in the Americas and even in northern parts of Europe, etc. So if it is affecting the whole body, then one needs to look at a resectional procedure together with a drainage procedure. Why do we want to do a resectional procedure? It's because you need what is the driver of chronic pancreatitis, and driver is inverted commas, because in my mind it's not really the driver. It's actually just it's because of the anatomy of the pancreas that 70% of the pancreas is located in the head of the pancreas. So we would do coring out procedures, and there's variations of that. And then of course, because our patients usually have a chain of legs, so they have multiple strictures throughout their main pancreatic duct, that we would then fillet the main pancreatic duct all the way up into the tail, and then we would do a drainage procedure onto that. So I'll leave it at that. If you have disease that is isolated only to the head of the pancreas, and the body and tail of the pancreas actually looks normal, and to my mind, not only looks normal on a CT scan, but needs to look normal on an endoscopic ultrasound as well. Because if it doesn't look normal on an endoscopic ultrasound, there's no point in offering a Whipple there, because the disease is progressive, and most likely the patient's going to then eventually develop chronic pancreatitis in the body and tail. But if you do have a normal body and tail, that patient you can manage with a Whipple's procedure, although it's obviously far more morbid. So the alternative there is, if a patient is not that fit and you're worried that they may not be able to withstand the morbidity or complications of a Whipple's procedure, you can actually just core out the head of the pancreas and do plop a loop of small bowel onto that. If we look at the resectional and drainage procedures, as you mentioned, there's various different types of them. So there's Frays, there's Burgers, there's an Itsibiki, etc. I think at the end of the day, they pretty much all do the same thing. We deal with the head disease, and I think that's why in our country, our patients tend to have very large head of pancreas pathology. So for us in our environment, a Fray procedure tends to be the best procedure that we have. If you have patients in your practice that don't necessarily have a very big head, or they don't have an inflammatory mass in the head of the pancreas, a good procedure there is probably a Burger, because there's very limited coring out of the head of the pancreas in that procedure there, although you do still open up the main pancreatic duct. Itsibiki, I'm not sure that there's much of a role for an Itsibiki. I'm not sure that there's many people that do it. I think there are some people out there that say if you are going to do an Itsibiki, then one should question whether or not the surgical intervention is actually indicated. But yeah, so that would be my opinion there. I hope that answers your question satisfactorily.
That's so satisfactory. Thank you so much.
I don't see any hands up. I see there's a comment in the chat room. Okay, there's the link to the questionnaire. Please go in and answer that. So click on that link and fill it in. I see there's now another hand. So let's just see who. How have I lost that? Okay, let's go back into participants now to find a hand. Khalid, I see your hand is up.
Thank you so much, Dr. Martin Brown, for your excellent presentation. I was just thinking outside the box. In my practice, where we basically diagnosed recently a young lady who had acute pancreatitis, and we established the possible cause in this case was intestinal worms. So in your experience and your practice, have you come across patients who have chronic pancreatitis, basically chronic parasitic pancreatitis? Because basically in this case, just thinking aloud, where you have the worms infesting the duodenum and the proximal ileum, which basically block the pancreatic duct. So that's my question. Thank you.
So I haven't come across that, but where that would fall in for me, thinking of what you've described, is under recurrent acute pancreatitis. And there's many causes of recurrent acute pancreatitis. And obviously there is a proportion of those patients that then go on to develop chronic pancreatitis. But I haven't specifically looked for that because that's not really a pathology, fortunately, that we see much in or at all in our environment. But I mean, I can imagine through recurrent acute pancreatitis, if that's what you see in your practice, then it's possible to get chronic pancreatitis through that mechanism.
Thank you, Doctor.
Sure. I did see that there was another hand up, but it seems to have disappeared. Or did I make it disappear? Was there another question? If there was, you can unmute yourself and ask.
Hi, Martin, it's Fiji here.
Hi, Vijay.
Hi, just regarding the worms, Scarus worms. I have seen over the years 1 or 2 cases of acute pancreatitis secondary to Scarus. The worm tends to crawl around. It goes into the ampulla, it may enter the PD, but usually it ends up in the CBD. But I've had, I think if I recall over the years, at least 2 patients whose first presentation was acute pancreatitis, and we were able to fish out the sort of worm from the CBD. Yeah, so I suppose it occurs, but whether it goes on to develop CP, chronic pancreatitis, yeah, that I haven't seen as yet. Well, maybe we haven't followed them up for long enough, but it's interesting.
Exactly.
Really interesting.
Exactly that. Cool. Thanks for that, Fiji. Are there any other? Okay, the hand has gone up. Mohammed.
Yeah, this Mohammed again. So just I have a question about the approach for disconnected duct syndrome in chronic pancreatitis. So
I've lost you.
Pseudocyst.
Sorry,
do you hear me?
Now I can hear you again. Do you mind starting again? I lost you where you said disconnected duct syndrome, and then you carried on. Can you carry on from there?
What is our approach? Do you go direct for a step-up approach, starting with endoscopic stenting, and then if that fails, you go for surgery, or what exactly your approach?
Yeah.
Syndrome?
So for me, the approach there is exactly the same as what we would do in trauma with a patient who's got a traumatic disruption of their duct. Endoscopic therapy, especially with stenting across, is a huge challenge. First of all, obviously getting to that area, it has to be quite distal. And the other problem is that you get stricturing where that starts healing. And once you remove the stent, typically those patients start stricturing down, and if you re-image those patients after 6 to 12 months, they typically have a strictured duct. So for me, again, the management there should be surgical unless the patient is not fit and not operable. And in the trauma scenario, it depends again on the patient and the mechanism, but typically those patients are quite young and fit, and that's an isolated injury because it's often onto a handlebar or something like that. The early surgery is possible because they are nutritionally normal. However, in the chronic pancreatitis patients that we're discussing here, it again, similar to with the obstructive jaundice, you need to look at the patient and see, are they operable? Most of the time they were not going to be, and especially if they get pancreatic ascites with that. So in those scenarios, if you can, initially up front again, we would do an endoscopic management of that, try to get across that breach. Often in this scenario, though, you can't because of the chronic inflammation and fibrosis, but it's worth giving it a try because you do need to make them operable. And then the surgical procedure of choice for me is, if there's a significant amount of body and tail left, is to do a central pancreatectomy. So where you just resect the fibrotic part of the pancreas, which usually is not a lot. It's very often 0.5 centimeter of resection, and then reconstruction. And our practice would be to do a pancreatico gastrostomy. But I mean, if you want to do jejunostomy, you can do the same. But at the end of the day, for me, it needs a surgical intervention, especially with that distal part, because they can get quite severe pain, and they can get, and yeah, it's primarily with the pain actually.
When you do your resection, do you do it like when you do your resection, is it kind of wedge resection and then you
I just lost you again. You're talking about a central pancreatectomy resection?
Yes, I'm saying, are you usually do it like wedge resection and then your reconstruction will be like side to side, or you take the center of portion of the pancreas and then you do your distal pancreas anastomosis with the bowel or the...
Let me just quickly look on my phone and see if I haven't got a photo for you. Let me just see who's in the meeting. It's much easier to show it to you in a photograph. Oh, Helga, do you have a photo? The one that you guys did a few months back. If you can find it and send it to me, then I can actually explain what we do.
I'll check, Prof, but I'm not sure I'll find that quickly.
Let me just quickly scroll through. If I don't find it in a couple of seconds, I will describe it to you. But it's much, as I say, it's much easier to do picture-wise. Don't believe it, do I not have it? Okay, never mind. It's going to take me too long. Okay, so if you think about it, if you look at a CT scan of this kind of a patient, what you find is that there's a clear area of almost like a pancreatic fracture, and you can see from distal to that the duct is dilated. Distal to that the duct is collapsed, and proximal to that is dilated. So what you do is in your surgical procedure, you would obviously open the lesser sac. So open the lesser sac, expose the body and tail of the pancreas up to the neck of the pancreas. In the acute trauma situation, it's very easy because you'll see that there's a hematoma at the site of fracture. You'd suck out the hematoma and you would see the fractured site. Obviously, with chronic pancreatitis, it's not that obvious. You have a pseudocyst usually. So what you would do is you open up the pseudocyst. And most commonly what you'll find in a pseudocyst is that there's a little orifice at the base of the pseudocyst, which is actually the proximal duct draining into the pseudocyst. What you need to do is once you've isolated that area, you dissect out the pancreas. And once I've done that and I've mobilized the pancreas off the splenic vein, which in a chronic pancreatitis setting is easier said than done, I do acknowledge that. It's not something that you're going to do phenomenally quickly. And then what you want to do is you want to mobilize probably about 4 or 5 centimeters of pancreas. What I do is I then if the transection in the pancreas is not complete, I make it obviously a complete transection so that you literally can fold the end of the pancreas up and you roll it off the splenic vein. You then shave the pancreas until you get to healthy pancreas and a healthy pancreatic duct. And again, as I say, that intense fibrosis is very rarely more than 5 millimeters. And then what I do is, my practice is that we would dunk that into the posterior wall of the stomach. And so what we do is you open the anterior wall, you make a very small incision on the posterior wall of the stomach, you put your stay stitches either at the 12 o'clock and 6 o'clock position on the pancreas. And don't ask me what 12 and 6 o'clock is, but at opposite areas of the pancreas. And then what you do is you pull those stitches from inside the pancreas. So you've gone through the anterior wall, you're now inside the stomach. You pull those sutures into the stomach, and then you very gently deliver the pancreas into the stomach. And you pull those 5 centimeters that you've mobilized, you pull all 5 of those centimeters into the stomach, and then you suture this in 2 layers. So the first layer is from the stomach mucosa, and you take a really nice deep bite onto the pancreas, and then very carefully, once you've gone all the way around in an interrupted fashion, and usually you'll end up putting at least so that what you would do is you start with a cruciate way of putting your stitches. So you put it at 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock. Those are the first 4 switches that you would place. The reason why you put those stitches is so that the pancreas cannot retract back into the retroperitoneum, and then you fill in the gaps in between. And typically what you'll do is put at least 2 stitches between each of those 4 stitches. So you end up with, how many stitches is that? 2, 4, 6, 8, 10, 14. So that's the number of stitches. And then you just gently come out of the stomach, reflect posterior wall of the stomach, and try find where the pancreas goes into the posterior wall of the stomach, and usually try put at least 2 stay stitches, if not 3, and that's your second layer of suturing. And so that is how I would do a pancreatic gastrostomy. So for me, I do a pancreatic gastrostomy differently. I don't do a duct to mucosa anastomosis, because I find that tends to stricture down in the long term. So for me, a much better procedure is a dunk procedure like that. So that is how we would do it in our practice. Is that clear?
Thanks, Brian. Thanks so much for this.
Okay. So
nice description. We lost the image, but we got a nice illustration.
Yeah, unfortunately, I don't. Yeah, haven't found the picture.
The image.
So I've lost you again.
I'm saying we couldn't get hold on the images, but we got a nice explanation here. Thank you.
No problem. Are there any other questions before we close the meeting? Your hand is still up, Mohammed Surah, so unless it's an old hand. Okay. Any other questions? Okay, please fill in that questionnaire in the chat room. And I think, or is there a new question? Okay, good. Then thank you very much for attending. And again, thank you for the Gastro Foundation for putting these things together. I think they're quite useful, especially for you guys, and also to the ECHO guys in New Mexico. It's great. Have a good evening, everyone. Bye.